Welcome back, future doctors. Today's explainer is a big one. We're tackling one of the most high-yield and, honestly, coolest topics in neuroanatomy, the dural venous and cavernous sinuses. As you transition from basic biology into clinical medicine, understanding the intricate plumbing of the human brain is absolutely essential. So, let's jump right in and make sure you walk away ready to completely ace those anatomy finals.
Here's our roadmap. We'll start with the dural venous sinuses intro, jump into the anatomy of the cavernous sinus, map out the tributaries and communications, look at the clinical significance, and then hit some exam prep MCQs to finish up. All right, Section 1, Dural Venous Sinuses Intro. Let's set our foundational macro view and establish a baseline.
So what exactly are these structures? Basically, dural venous sinuses are the brain's drainage system. But wait, they're not your typical veins. They are endothelium-lined spaces with absolutely no muscular coat, and crucially, zero valves. This valveless feature? Total game changer, especially for the spread of infections, which we'll get into shortly. Anatomically, most of these sinuses are perfectly sandwiched right between two specific layers of the cranial dura mater, the outer endosteal layer and the inner meningeal layer.
Now, a classic exam question will ask you to classify the 21 major sinuses. To make this easy, just remember the rule of sevens. You've got 7 paired sinuses, meaning they exist on both the left and right sides of the skull, like the cavernous and transverse sinuses. Then you've got 7 unpaired sinuses, which run right down the midline of the skull, like the superior sagittal and straight sinuses. Lock in that basic classification and you're already ahead of the curve. Moving right along to Section 2, Anatomy of the Cavernous Sinus. Time for our micro deep dive into the absolute star of the show. The cavernous sinus is fascinating. It gets the name cavernous because its interior is divided by this network of connective tissue trabeculae, creating tiny little caverns. It sits right next to the sphenoid body and the pituitary gland. But here is the wild part. What makes this so heavily tested is that it's the only spot in the entire human body where an artery travels completely inside a venous structure. Let's map out exactly where these critical nerves and vessels are spatially positioned. Okay, highlight this golden fact in your notes right now. Look at the lateral wall. Nerves 3, 4, V1, and V2 are firmly embedded in that wall. You can easily remember them from top to bottom with the mnemonic O-tome: oculomotor, trochlear, ophthalmic, maxillary. But the internal carotid artery and the abducent nerve, cranial nerve 6, they don't sit in the wall. They plow straight through the center of the venous blood. Because the abducent nerve is just bathed directly in this blood, sitting inferolaterally to the artery, it's incredibly vulnerable. Any pressure change or infection inside the sinus, and nerve 6 is the very first casualty. Let's move to Section 3, Tributaries and Communications. We need to trace how things flow in and out of this hub. The cavernous sinus isn't an isolated pool. It's a massive venous hub, communicating with the orbit, the meninges, and the brain. You absolutely must memorize this sequence. It maps the exact route an infection takes from the dangerous area of your face. Think of a squeezed pimple on your nose, straight into your cranial cavity. It travels from the facial vein to the deep facial vein, into the pterygoid venous plexus, up through an emissary vein, and bam, dumps straight into the cavernous sinus. Because there are 0 valves in this system, blood and bacteria can freely flow right backward into the brain. This brings us to Section 4, Clinical Significance and Pathophysiology. Let's see what happens on the wards when this anatomy goes wrong. When anatomy fails here, it fails spectacularly. On the left, we've got cavernous sinus thrombosis. That facial infection we just talked about, it causes a septic blood clot right in the sinus. Because cranial nerves 3, 4, and 6 are instantly compressed, the patient presents with ophthalmoplegia, total paralysis of the eye muscles, along with some really severe, deep pain. Now contrast that with the right side, an artery-venous fistula. Imagine a skull-base fracture that actually tears the internal carotid artery inside the sinus. High-pressure arterial blood aggressively blasts into the low-pressure venous sinus. This violent pressure forces blood backward into the eye's veins, causing the eyeball to literally bulge out and pulsate with every heartbeat. It's called pulsating exophthalmos, and you'll even hear a loud rushing sound, or a bruit, right over the eye. Section 5 is our quick revision and summary. Let's make sure we've locked in the essential takeaways before we test you. All right, here are the 4 golden facts you need to remember. First, the anatomical exception. The inferior sagittal and street sinuses sit only within folds of the meningeal layer, not wedged between the 2 dural layers like the rest. Second, 0 valves means intracranial infections can spread bidirectionally.
Third, the abducent nerve is highly vulnerable because it runs right through the middle of the sinus. And fourth, this is an amazing piece of physiology. The physical beating of the internal carotid artery actually acts like a mechanical pump, actively expelling sluggish venous blood out of the cavernous sinus.
Finally, Section 6, Exam Prep MCQs. Time to flex those active recall muscles. Let's hit you with 3 rapid-fire questions sourced straight from standard textbooks. First up, all of the following dural venous sinuses are paired except superior petrosal, inferior sagittal, or cavernous. Think back to our rule of 7s. And the answer is C. The inferior sagittal sinus is firmly on the midline, running right in the free margin of the falx cerebri, which makes it strictly an unpaired structure. The cavernous and petrosal sinuses, as we discussed, definitely have a left and a right. Moving to question 2. This is a classic exam trap about the cavernous sinus contents. The lateral wall contains all of the following nerves except oculomotor, trochlear, ophthalmic, or abducent. If you answered D, you nailed it. Remember the OTOM mnemonic? Oculomotor, trochlear, ophthalmic, and maxillary are embedded safely in that lateral wall. The abducent nerve is the lone wolf running straight through the blood-filled center alongside the internal carotid artery. Last one. Let's test your foundational knowledge of dural layers. All of the following dural venous sinuses lie in between the 2 layers of dura mater except superior sagittal, inferior sagittal, superior petrosal, or inferior petrosal. The correct choice is B. While the vast majority of your dural venous sinuses act as wedges between the outer endosteal and inner meningeal layers, the inferior sagittal sinus, along with the straight sinus, are the big exceptions. They sit exclusively within folds of the meningeal layer itself. So as you pack up your notes and prepare for the wards, keep this provocative question in mind. How might a simple infection in the dangerous area of the face permanently alter a patient's vision? Well, now you know exactly how. You understand the valveless venous pathways, the precise location of the cranial nerves, and how a facial infection can literally hijack this system to travel straight to the center of the brain. Never underestimate that direct highway. Keep studying hard, and we'll see you in the next explainer.